Good morning to some of you on the line, and good afternoon to others that are here in the Central Standard Time. On behalf of the American Heart Association, St. Louis staff and volunteers, I want to thank you all for joining us today for our first in a series of upcoming community conversations on COVID-19 and cardiovascular diseases. The American Heart Association is deeply concerned about the public health crisis facing our country. Our top priority regarding coronavirus, COVID-19, the disease, is the health and well-being of individuals and their families today and in the future, not only in the St. Louis region or our state, but in every community everywhere. This is a challenging time for all of us, and we want you to know that we are in this together. I want to first and foremost offer our sincere, heartfelt thanks to those individuals risking their own health on the front lines daily, to all the doctors, nurses, technicians, maintenance, and food service workers, thank you. To all essential service personnel in our communities, thank you. Depending on where you are tuning in from, you've been under a stay-at-home order for a few weeks or maybe just a week now. It's our goal to keep you, the public, informed and to also provide you with support and resources available through the American Heart Association. We aim to be a trusted voice in this noisy, chaotic environment of this coronavirus pandemic. I am pleased to have an impressive panel of health leaders joining me today. They are all renowned for their expertise both locally and nationally. First, I want to introduce Dr. Denise Hooks-Anderson, Associate Professor in the Department of Family and Community Medicine with St. Louis University Medical School. She is a practicing physician with Flu Care Medical Group and President of the American Heart Association St. Louis Board of Directors. Board certified in family medicine, Dr. Hooks-Anderson is a member. Sorry, we're getting some feedback. Dr. Hooks-Anderson is a member of the American Academy of Family Physicians, the National Medical Association, and the Missouri Academy of Family Physicians. Next, we have Dr. Peter Panagos also joining us. He is Professor of Emergency Medicine and Neurology at Washington University in St. Louis and Director of Neurovascular Emergencies in the Division of Emergency Medicine. Dr. Panagos serves on the local American Heart Association Board of Directors and numerous national leadership committees. He is the current chair of the Stroke Council Leadership Committee of the American Stroke Association. I'm also pleased to introduce Dr. Eduardo Sanchez. Dr. Sanchez serves as Chief Medical Officer for Prevention and of the Center for Health Metrics and Evaluation for the American Heart Association. He is board certified in family medicine and has an extensive background in public health, having served as the director of the Institute for Health Policy at the University of Texas School of Public Health and as commissioner of the Texas Department of State Health Services. Again, thank you all so much for being here today to share the latest in COVID-19 news, research, and resources in the community. I'd like to jump right in and invite Dr. Hooks-Anderson to help get us started. The format for today is a conversation. So we just want to be kind of informal, giving our audience a chance to hear directly from experts on the current pandemic and how it's affecting our communities. First, Dr. Hooks-Anderson, thank you for being on the front line of this pandemic. Thank you for your commitment to the patients and to the volunteers and staff of the American Heart Association.
Good afternoon, everyone. Thank you to Damon for inviting me to this panel. St. Louis right now is an interesting place. Our country right now is in an interesting place. We are having to adjust. This is a time that we are having to think differently how we do things and how we will manage this crisis. As a family physician, we've had to adjust. Many of my colleagues who work in the outpatient setting, we've had to adjust our practices to deal with the pandemic of COVID-19. We are no longer, many of us are no longer seeing patients in the office. We are having to actually see patients via Zoom like we're doing today to try to keep staff safe and to try to keep our patients safe. And this adjustment is new for all of us. We're also, as outpatient providers, being asked to assist our hospital colleagues. For instance, many of our colleagues who work as hospitalists or who work in the hospital are doing a lot of the heavy duty work, working with a lot of the COVID-19 patients. So the hospitals are needing providers to actually assist those patients that don't have COVID, who are being discharged from the hospitals, who can't see their physicians because their offices are closed. So many of us are being asked to also help in that area as well. So again, adjustments are being made in our economy, in businesses, as well as in the healthcare sector.
Thank you, Dr. Anderson, for sharing, insight on the new normal of seeing patients and keeping them safe in the outpatient setting. I want to ask, how do you think we are doing as a region when we talk about the regional stay-at-home orders?
So what I find interesting about St. Louis, I'm not native to St. Louis, so one of the first things I noticed about St. Louis when I moved here is there were all of these individual municipalities, and each with their own local governments, their own local police force, their own way of doing things. COVID-19 has caused us to work together. It has allowed us to collaborate and to think outside of the box as to what we need to do to help decrease the amount of cases here in St. Louis. So I'm grateful that our county and city governments were able to come together to agree to a shelter-in-place order, because COVID-19 does not discriminate. It's not a city virus. It's not a county virus. This virus affects all of us individually. It's affecting our economy, our education. So all of our educational systems, our healthcare systems, our governmental agencies, our public health officials, we are being forced to work with one another. And I hope this collaboration and this willingness to work with one another will continue past this pandemic. The pandemic is not over. We are seeing these high cases of the COVID infection in African Americans, for instance. So we are needing to address that to make sure that the people that live in North St. Louis and in North County also have access to testing facilities. So again, this pandemic is forcing us to make sure we continue to work with one another so that our cases, we can slow the curve in the COVID cases.
Let me ask you this. What should someone do if they experience coronavirus symptoms? How should they respond or protect themselves, those sorts of things?
So first of all, just to be knowledgeable about the symptoms. The main symptoms of COVID-19 are the coughing, the high fevers, the myalgias, shortness of breath. Some people have even reported diarrhea. And so if you have these type of symptoms, first of all, you should already be in a shelter-in-place order, but you should definitely stay home. You need to call your doctor and to alert he or she about your symptoms. The doctor will then direct you to a local site if he or she feels like you need to be tested.
What if someone doesn't have a regular doctor?
Well, there are sites available for people who don't have insurance. Many of the community health centers, like Family Care Health Center that has a South City site and a Mid-City site, Athenia Healthcare, Care St. Louis, all of those places will offer testing to people who do not have insurance.
Thank you. We know, there are those in high risk categories, and you talked about some of those, like, those with heart disease and stroke survivors, those that are over the age of 65. What should these individuals know about COVID-19 and their potential risk?
So they should just understand that they are at increased risk. So we're talking about the elderly population, people older than the age of 60. We're talking about people who are immunocompromised with autoimmune diseases, for instance, people who are on immunosuppressive drugs, anyone with an underlying condition like hypertension, diabetes, heart disease. All of these individuals should know you're at an increased risk. So you have to follow the guidelines and the recommendations from our public health officials who ask us to shelter in place. If you have to go out for necessities such as groceries or your medications, you need to be wearing some type of covering over your nose and mouth. You need to wash your hands regularly, and even more regularly, with soap and water or using hand sanitizer. It's best if you can stay away from large crowds. You need to be following the social distancing order. And that's the same for your families. I've been seeing people who are sheltering in place, but still allowing relatives to come in and out of their home. Again, that necessarily isn't sheltering in place and keeping social distancing. So we need to remember those things, because if we don't, we're putting those people at risk.
Thank you so much, Dr. Hooks-Anderson. I'd like to turn now to Dr. Peter Panagos. Dr. Panagos, thank you so much for joining us today. And we know you are in the ED on the front lines. How do you think we're doing as a region?
I kind of echo a lot of the sentiments of Dr. Hooks-Anderson. I think we are, as not a native of St. Louis, I certainly have a different perspective, and my kids now are natives of the city. I certainly applaud the degree of cooperation. I think well ahead of the curve for our region between the city and county. And I think that is going to serve us well long-term and short-term. And I think we're seeing the benefits of that now, that we have not really overrun our healthcare system. There are some examples of hotspots and kind of blips, but in general, our system has been I think structured and prepared to kind of weather this type of pandemic, if you ever can prepare for that. And we can have arguments that, were we prepared for this to begin with? But that's an after action item that we can talk in months when we're all sitting together in a room and sharing our experience and how we can be better the next time. But I think overall, I think we are prepared. We are ready for any kind of big surge in patients. But it really is kind of a team sport. As an emergency physician, we see patients who maybe don't have access to care and are worried. And we serve as educational and reassurance. We see people that are sick and they need inpatient care. And we're working really closely using innovative technologies such as telehealth and telemedicine. We're relying, and I'm so thankful for the outpatient primary care community that's able to manage a lot of these patients with chronic diseases and keep them in their home and in their community and avoid coming to the hospital, because we are there 24/7. We love and we're honored to take care of sick patients. But at this time in our history, being in the hospital, if you don't need to be, is not the place to be. So I'm very thankful to our primary care community. So I think overall we are in a good place. St. Louis, I think, has very good bed capacity at this point. We hope to never exceed it or meet it. But as of today, decisions we've made a few weeks ago, we're, I think, in a good place. But premature closure and kind of getting and kind of going back to business as usual too soon, I think it could change the narrative completely.
Thank you. Thank you. As a staff, we hear anecdotally that people are experiencing heart attack or stroke symptoms, are not calling 911 or delaying getting treatment due to fear of getting COVID-19. Can you share what emergency rooms are doing to be available for these types of emergencies?
Yeah, I would say to healthcare providers, to the primary care community, to patients, family members out there, the emergency department is open 24/7 for heart attack, stroke, and trauma, and acute medical disease and illness. Nothing has changed. We are there, and that's what we do well. So I do not want people to stay at home and wait this out. We are seeing, and some of this is anecdotal, it hasn't been published yet, but across the region with colleagues in California and Canada, Midwest, Cleveland, Chicago, elsewhere, that are our presentations for just, for example, stroke are down about 50%. We're seeing moderate to severe stroke still presenting to the emergency department, but that overall mild stroke and TIAs are electing not to come, even when recommended by their primary doctor. So that scares me, and I don't know what that's going to look like on the other end. I still think if patients are feeling they're having a stroke, feeling that they're having a heart attack, use the EMS system, activate, call 911, and we are there to take care of you. I don't want people to avoid coming to a hospital for potential life-threatening illnesses.
Can you share any insight on how you are protecting non-COVID patients? Are there new procedures for stroke code, STEMI patients, traumas, things like that?
Yeah, this is what makes, I think, today very exciting. And I think if you take 10 people from 10 different centers, even across a region, the amount of innovation that is going on is truly remarkable. And the things we're doing today and the speed that we're doing things today to implement process change traditionally would take months and many committee meetings, and then more committee meetings. But now we're implementing those within weeks or days, and it's truly remarkable. Things that we've done, and I can speak from my center. We have instituted a screening trailer outside our emergency department for low risk, worried patients with COVID type symptoms, or maybe not, to able to screen them, reassure them, order appropriate testing, and trying to keep them out of the hospital setting, but addressing their needs and testing them appropriately with really good follow-up. We have implemented tele-technology within our own emergency department. Most of our COVID positive rooms or COVID under evaluation rooms have iPads, so patients and staff can communicate after that initial interaction, so we don't have to go in and out of the room frequently with excessive PPE, exposing staff to repeated COVID type symptoms and preserving that precious PPE that is a very hot topic in the news. And then even our consultants, neurology in our institutions, are using telestroke within our emergency department to evaluate patients in our own ED, where traditionally we've done this in the community. So we're being innovative and trying to protect staff and give patients excellent care.
Wow, it's great to hear about that innovation and how basically rapidly everyone's responding. We know that for stroke and heart disease patients, rehab is a critical part of recovery. What is the recommendation for these patients who may be in the first few weeks or months of their recovery?
I think the same things as we had heard as far as patient and family protection. Still, if you've had a stroke or had a heart attack, there's a very good chance you have risk factors such as diabetes, hypertension, obesity, maybe tobacco use or abuse. So that puts you at higher risk for COVID. So still the same rules go into effect as self-isolation, mask, avoiding sick contacts, and really kind of staying in place. Certainly inpatient rehabilitation services are still available for patients who require that. And outpatient services are being used as needed. And then we still are seeing telehealth in the setting of outpatient rehab that's being used much more frequently. I know colleagues in doing physical therapy via telehealth. That is an innovative way of doing this type of outpatient rehab. So the story and narrative is being rewritten as we sit here, and people are becoming much more innovative in how we provide care to the patients they need.
Thank you. Well, one last question. As an emergency room physician and AHA, being part of the AHA leadership volunteer, what is your message to people on the call today?
My message, overall, and I think I stated earlier that, if we need to tell our patients, our families, in our community that if you still, speaking as someone who's wearing an AHA hat, if you feel like you're having a heart attack, feel like you're having a stroke, or if you're uncertain, still accessing the medical system and going in to seek care is still recommended. I think traditionally we would say call 911 and come to the hospital. With the COVID-19 crisis, does that involve a interaction with your primary care physician? We're doing things today that we never thought we'd do a couple months ago, but that still may be a screening point for a lot of patients. But I still think if you think you're having a stroke, if you think you're having a heart attack, is seeking medical care now versus delaying it, I think is the best recommendations I can make. We're available. We're open 24/7. We're happy to take care of people.
We appreciate you, Dr. Panagos, and thank you for being on the front lines of this pandemic right here in St. Louis. Next, I'd like to turn to Dr. Eduardo Sanchez, Chief Medical Officer for the American Heart Association and trusted voice for staff and volunteers within the organization. Dr. Sanchez was here back in December during our hypertension summit, and he always is very insightful, and so we thought it would be best to have him here today because we love his thoughts. And like I asked our first two panelists, Dr. Sanchez, we're several weeks into the regional and national stay-at-home orders. How do you think we're doing as a country?
Well, I always like to say we're doing better today than we did yesterday, and hopefully we'll do better tomorrow than we're doing today. So more and more states are coming online. I think people are beginning to understand the seriousness of stay at home. Let me put that another way. I'm hoping people are understanding the seriousness of staying at home. And I think that the good news, one of the good news insights is that it appears that in those places where stay at home has been put into effect and has been in effect for a while, we're beginning to see some of the really disturbing projections get recalibrated, and the numbers are coming down. Let me be clear, and let me start with this. Not only thank you to those who are doing the work on the front lines, including public safety, but also those who are putting themselves in harm's way by doing the essential services like having supermarkets open that we can go to and buy food. And I also want to express my sincerest condolences to anybody who is has suffered in their family a death due to COVID-19. Oh my God, every day that I look at the obituaries and you see people whose names you know, from Ellis Marsalis to John Prine to so many others who in one fell swoop are being taken by this disease. And those who have family members who are going through this right now, my sincerest condolences and my thoughts and prayers are with them. Let's put this in context. I think we're doing better. I just wouldn't be Eduardo Sanchez if it didn't say I am frustrated because I feel like this didn't need to have gotten where it has, but we can't change that now. And I just want to underscore what Peter said. There will be a time, and AHA and others of us need to be at all the tables, local, state, federal, organizational, after action reports that are about how do we never, ever let this happen again. All three of us who are presenting are parts of learning organizations, either in our jobs or the organizations we're associated with, and we need to apply the notion of quality improvement and doing things based on science and anticipation for the future, because this won't be the last time that such a thing happens. Hopefully it'll be the last time it happens this way. Globally, some really, really astonishing numbers. More than 1.5 million cases of COVID-19 in the world, almost 100,000 deaths. I have no doubt we will surpass 100,000, maybe by the end of the day, definitely by the end of the weekend. In the United States, 464,000 cases, almost 17,000 deaths. I believe we will be at 500,000 cases by the end of the day or by the end of the weekend. Missouri is looking a little bit different, but I would say that I think that Dr. Hooks-Anderson and Dr. Panagos would agree that this isn't playing out in the same timeline in all our communities. And what we're seeing in New York, while I don't think that's what we're going to see in most of the other parts of the country, New York was several weeks ahead of most other parts of the country, and the Midwest is only beginning to see what I think has happened in the Northeast. I'll wear a AHA hat for a moment. We've been tracking COVID-19 by region, and St. Louis is part of the Midwest region. A lot of the action, most of the action has been in the East region, the states that are in the Northeast, and there's a slowly increasing percentage that's moving west and south in the country. And so I think we're going to see more cases. Missouri, about 35, 39 this morning cases, 3,539, and almost 100 deaths, 94. St. Louis City, is a little busier than, St. Louis County has a little bit more activity than St. Louis City. The two combined, if they're not duplicative, is about 2,000 cases and about 41 deaths in both. As I heard said by, I think, Peter and maybe Denise as well, Greater St. Louis is really complicated. It's not only multi-county, but the two counties, the counties come from two different states. And so I can only imagine that it takes a different level of cooperation to make things happen when you have that many jurisdictions involved. A few things to say. What we can do, I think that every single person on this call and anybody you influence, let's remember, right now, the best control is what you do as an individual and what those in your immediate sphere do. Stay at home, wash your hands regularly. When you touch your face, wash your hands, make sure surfaces are clean. Stay 6 feet of distance from people that you don't know. And back to the point that Dr. Hooks-Anderson mentioned, if family members come visit, treat them as if they have COVID-19, quite frankly, and they should be acting that way as well. And one of my messages is, act as if you are contagious and act as if every single person around you is also contagious. And if we all did that all the time, even when we are in in line of sight, we could we could improve what we're getting from our separation. I think it is important to mention a few other things. That is that not only do we need to be cautious as individuals, but if indeed you are somebody who is 65 or older, particularly people in their 80s and older and people in their 70s, please, 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 you yourself be careful. And if you are around them, if that's your grandmother or your mother, act as if you have COVID-19, and maybe it's not a good idea to go visit them. Wave outside the window if you can muster that. I have a mother-in-law a mile and a half away. We're doing a lot of email communicating and phone talking. I have not touched her in 4 weeks. We wave, and she's good with that. She cracks her shade. She looks and waves and smiles. We need to do that. Medical conditions are another thing, another factor. If you have cardiovascular disease, diabetes, morbid obesity, neurologic disease, please, please, please be careful. And those who you know have them that are in your family, act as if you have COVID-19 and act accordingly. I think that home and work circumstances are something we need to think about. Not only are people put in harm's way, but let's be all acting as if we have it, or that others have it. And let's advocate for the protection of those who are doing those essential services, everything from working to working in the supermarket to working in the hospital. And lastly, there's now some really good data about smoking and vaping, putting people at risk. Who is surprised that if you are doing something that may damage your lungs, you're going to put yourself at higher risk? But the things we do when we are smokers or vapors, not that I'm one, involve your hand approaching your mouth a bunch, and that's just not a good thing right now during COVID-19. Last thing, Damon, what's AHA doing? One, we are involved in trying to provide clinical care advisories. We've updated CPR guidelines and are providing training opportunities for frontline staff who are wondering, what do I do if that person has COVID-19, even if they do have a cardiac arrest? We're providing that training. We're providing training to clinical care, physicians about what medications, how not to just stop medications. And in some instances, we've provided an advisory on what might be some precautions that need to be taken around the use of hydroxychloroquine. And if you're on this call and you haven't heard the words hydroxychloroquine or the word, where have you been? You haven't been on the planet. We're hearing it over and over as a treatment for COVID-19. We at AHA don't feel comfortable saying we should be using that to treat. The science does not yet give us the level of comfort that we ordinarily need to say that would be a good idea, and we know how it ought to be prescribed. We have, as an organization, put out a call for proposals, $2.5 million to stand up a coordinating center and do 10 to 15 rapid response research investigations. For those 10 to 15 opportunities, 700 applications came in. And we are looking for more volunteers to help review those 700 so we can narrow it down to the 10 or 15 that are going to get awards, and hoping that there are others who see that there's tremendous interest in this and put money forward that can help support research that needs to get done. And then lastly, we've stood up or are standing up a COVID-19 registry. So we're going to build on our get with the guidelines platforms that we have in hospital settings that help improve quality and follow the data on how we do taking care of people who've either had stroke or heart failure and some other things. And we're going to create a COVID-19 registry where we are going to track what happens with COVID-19 care, trying to get insights into the encephalitis that seems to be associated with manifestation of COVID-19 in some folks, the myocarditis that seems to be a manifestation of COVID-19 in other folks, and the increased likelihood of a bad outcome by age, by race, ethnicity, and by underlying medical condition. We will know more because of the COVID-19 registry. And lastly, I said it at the first, I'll say it again at the end here. We will be at the table when we do the after action, because we as an organization feel like we cannot let this happen again. And there's some things that coulda, shoulda, would have been in place. They weren't in place. Here we are. We can't let it happen again. I'll stop there, Damon.
It's an understatement to say that was a mouthful. I appreciate everything you just said. I'm sure the audience was taking copious notes, and we'll get plenty of questions from everything that you laid out. One thing I did want to ask you, though, you talked about, things that are being discussed nationally on news coverage and things like that, knowing that there have been news articles on how the coronavirus is disproportionately affecting people of color in some communities. Can you share any comments on this and help us understand why?
Sure. Well, Damon and Denise and Peter, you've all been a part of the American Heart Association. There's a couple of things we know. We know that the prevalence of things like hypertension, as an example, among African Americans is substantially higher, and more importantly, not only high blood pressure, but uncontrolled high blood pressure is higher among African Americans than virtually any other group. And then when you throw in type 2 diabetes, which is highly prevalent compared to others among African Americans, Latinos, and American Indian, Alaska Natives, I think that is part of the explanation. I think part of the explanation is people's access to care. Dr. Hooks-Anderson, I'm going back and forth with first name and doctor name. I'm not a doctor person, so I'm just doing my best. But Denise was saying earlier that in some places people don't have access to testing. And it's one thing, I wish we could all just act as if we have the condition, but the truth is that we would act differently if we knew we had the condition, but more importantly, our public health authorities would have some ability to begin doing some contact investigation and identify who else might have been contacted and then do the testing there. So in the best of worlds, individual testing is not about just knowing one person is positive, but it's knowing that one person is positive and trying to find out who else did they have contact with and test them as well. That's a smart way to do it. That's where we need to get. So back to the question about the insight. The other insight is that folks who are lower income, A, less likely to have insurance, but B, more likely to work in the kinds of jobs and in the kinds of settings and live in the kind of conditions that put people at risk. It's one thing to say you should be 6 feet away from people if somebody were to get sick in your home. If you are sick at home and you live in a house where there's only 1 bathroom and 2 bedrooms and 6 people, and I'm not to judge, not to anything, though some people have to live that way because that's the best do because they don't earn enough money to live in more splendor. And I'm being facetious. It is very, very hard to do the things that we are telling people to do to protect others from getting COVID-19. So when you put all of that together, I don't think it's a surprise, but I hope that in our after action we say we got to address this, because when these things happen, these are the factors that then accelerate a pandemic, and the only way to slow it down is to begin to think about living wages. people living in situations where there is space. People have the money to have, they have access to healthcare. And oh, by the way, I think Dr. Hooks-Anderson is understating some of the challenge at primary care. And I don't mean this to be judgmental. I want you to nod your head. What I'm seeing in the family physician community is we are taking a beating because the way we normally pay our bills is by people coming in to see us, and they can't come in to see them. So part of a pandemic response is primary care practices have to have the personal protective equipment that allows them to be available to their patients who right now are too afraid to get out and be seen and be out and about. So I'll stop there. That was just a little bit.
Thank you again, Dr. Sanchez, for all you and your team are doing on behalf of our communities. And I can truly say it's great to be a part of an organization that is truly of the community. And in the face of all the different challenges that all three of you have laid out, you know, we're continuing to seek out and deploy innovative methods that allow us to bring value to our communities and continue to support quality and equitable health and wellness for all. Recently, I saw a quote that read, outstanding people have one thing in common, an absolute sense of mission. I believe that, you know, that each one of you exhibit this, knowing that, you know, the relationships that we've had and we've seen you in action, you guys are really outstanding people that have that absolute sense of mission in mind. So your commitment to the community and the overall mission of the American Heart Association, we're thankful for that. It helps drive impactful change in our communities, and we're so grateful that each one of you were able to make it today and for bringing your answers and clarity to the community during these unprecedented times. We're kind of going to move to our question and answer. I like to call it the rapid round session, where, you know, participants will get a chance to leave their questions in the chat box. We've had some that have you know, we've received in preparation for this meeting, so we'll get to some of those while we monitor the chat box. The first one we want to direct to you, Dr. Sanchez, and you've already talked about some of this. Social distancing is our new normal, but as humans we get impatient. Why is staying the course with social distancing so important?
Because listen, people are the only thing that's spreading COVID-19. And so the degree to which people are not connecting with other people physically, and you might have said social distancing, and I'm trying to discipline myself to talk about physical distancing, and we need to stay socially connected but physically distant. I had the opportunity on Saturday to spend some time on an Empowered to Serve webinar, and it is so important that our faith community leaders embrace the idea that being physically distant does not equal being spiritually or socially distant. And the same way that I heard Peter and Denise talk about innovation, I heard that there is innovation at work in the faith community across all denominations. Some are embracing it more with more passion than others, but physical distancing is the one thing that we can control. And as I said earlier, there are so many things where we depend on others, whether it's a medication or our doctors or a hospital to take care of ourselves. And this is a situation where we can be, to some extent, the captains of our own destiny by staying home and keeping ourselves acting as if we're contagious, which includes physical distancing. Denise, it looked like you wanted to say something. Please do.
Yeah, I just want to jump in there and say that the COVID-19 virus spreads easily. And what we know so far is that it's spread by droplets. So when people cough or sneeze, or even if you're in conversation with them and you're within that 6 feet distance, the virus could spread. The virus can be on surfaces. So that's why when we talk about being physically distant, I like that, Dr. Sanchez, that's why that's so important, as well as the frequent washing of hands or using the hand sanitizer, cleaning down your surfaces with appropriate cleansers is so important.
And Damon, this
Yes, sir.
flashed to me a second. I have a homemade facial covering because I do think we need to add that part of the message that we're trying to get out there is use those facial covers. That is about keeping yourself as a person who may have COVID-19 and no symptoms from spreading it to others. Mine is pretty lame, but it works. I took a handkerchief that was actually left to me by my dad. It's monogrammed, and Peter and I probably have never used a handkerchief. It was a thing from a past generation. Using it now, put it on my face. It covers my nose, covers my mouth, and that's what wearing facial covering is about. It's about protecting others. And I'm doing this also because I'm a brown person. I've experienced life as a brown person, and I am willing and think it is a good idea for all of us, brown, black, white, to put these masks on. And if you feel like you need to put something there to disarm somebody, put a funny picture, put a funny word, but wear a mask.
Thank you. Thank you both, Dr. Hooks-Anderson. I appreciate that insight as well. I want to go back to Peter for a second. Dr. Panagos, I know you may help patients in the ER with this one, this one question. There's increased anxiety in general these days. Can you share how to tell the difference between the chest tightening of a panic attack, a potential heart attack, and COVID-19? And what should someone do?
Yeah, that's a great question. Yeah, I wish I could. I would package that and market that as a diagnostic test, but it's difficult. We see patients with COVID-19 who present to the ED with severe cough and chest pain due to musculoskeletal strain, inflammatory disease, airspace disease that's causing chest wall pain. So how to differentiate that from the pain related to cardiac pain? We all know the kind of the classic signs and symptoms of cardiac pain. No, I don't tend to see people present classically anymore. So, the difference between someone with COVID-19 and a fever, cough, or airspace disease or pneumonia, someone with cardiac symptoms of kind of chest pain, dull pressure, it's a tough distinction. And I think that's where I just ask that people don't stay at home and just wait it out. At the minimum, discuss that with your primary care physician or your clinic on what next to do. And if at all concerned, then certainly come to the emergency department where we can help to differentiate that. Sometimes it takes me more than a history. It may take an EKG, it may take a chest x-ray. It takes things a little bit more to get objective data to say, I understand your concern. We don't think this is a heart attack. I don't think this is pneumonia. It's not a collapsed lung. This could be anxiety, and I understand that completely. We live in a very anxious time in this world, but at least we can have that face-to-face and kind of meet everyone's needs.
And Damon, if you don't mind, I'd like to talk about the anxiety.
Sure.
It's really important that people stay connected with their primary care providers during this time, because anxiety is a real issue right now. And even though we are recommending the shelter in place recommendations and the advice from our public health officials, that doesn't mean that we stop exercising or we stop doing the things for our mental health. So exercise helps our mental health. It helps improve it. It lessens the depression. It lessens the anxiety. And there's several exercises that you can do in your home. There are YouTube videos that you can find that will give you just different exercise programs. You can talk to your family on the phone via Zoom, FaceTime, which helps lessens your anxiety. So if you are becoming more and more anxious, you need to reach out to your primary care provider, because maybe sometimes people need medication to help control their anxiety. So during this time, just because you are sheltering in place doesn't mean you have to be distant from your doctor. I mean, your doctors are available via Zoom, via telephone. Please reach out if you feel like the anxiety is getting out of control.
Thank you.
I'm going to add one more. I'm just going to keep adding because I think it's all positive.
Great.
I couldn't agree more that one way to address anxiety and what might be depression and what is absolutely increased stress is by doing the things that we say people should do, eating healthy, being physically active, getting enough sleep. But one of the others is there are ways to be connected to others in your community, particularly if you live, depending on where you live. So I live in a place where there's houses on the street, and I happen to live in a cul-de-sac. And I'm just sharing this because innovation and creativity didn't come from me, it came from one of my neighbors. He reached out to all of us, and yesterday we had a trainer come who pulled up. I was in the middle of the cul-de-sac. The families that participated, there were at least 2 people from each, were basically in their yards or right in front of their house. And we had 10 people doing a group exercise. Are we going to do that every day? Absolutely not. But I'll tell you what, there was a sense of social connection, even though we were really physically distant. I mean, the people closest to me were 50 feet away. There was a sense of shared mission and shared accomplishment. And I guarantee you that we were all so beat by the end of that whatever anxiety we had got at least moved out of the way for a little while. So there are ways to be creative, and there are ways to do some things, whether it's a dance in the yard or whatever it may be. There are some things that we can do creatively to connect socially and to kind of de-stress a little bit.
Thank you all. We've consulted the chat box, and I'm going to summarize here. But within the chat box, there's conversations about medication shortage. And Peter, I want to volley that one to you and see if you can elaborate or provide any insight on this.
Yeah, certainly the issue of medication shortage is not a new issue facing us in the healthcare environment. For the past several years, at times, due to the supply chain of medications that have been at shortage, and we've kind of had to adapt and really on the fly and kind of come up with new options. As far as the specific one was in the group chat, I believe it was for an IV thrombolytic TPA. And there's some very good responses to that, as far as talking to your local pharmacy, your local customer service rep of the pharmaceutical company Genentech, who happens to be the only manufacturer of TPA, and then working within a system. I find that communication amongst systems and hospitals, and no one's really practicing alone. I know in my system we have multiple hospitals, and if one hospital was having a shortage of a particular life-threatening drug, we would certainly reallocate resources to make sure that everyone got the best care available and shouldn't be penalized for going to their local hospital. So, I think drug shortages are things of the past, present, and future. But I think communication and awareness and cooperation probably will get through this.
Well, along with that, can you talk about drugs for preventing or curing COVID?
Yeah, that's a great question. I'm not aware of aside from the very excellent points we've heard so far from our other speakers as far as prevention, and those are very inexpensive and in some regards, staying away from being exposed to people with disease. There are no medications that are going to prevent, drinking tonic water is probably not going to prevent COVID-19. It may help you relax a little bit more if you put some gin and vodka in it, but we don't want to advocate that as a prevention strategy. But there's really, aside from staying well, self-preservation, taking care of yourself, exercise, rest, taking your medications, or maintaining chronic disease, that's probably the best drug out there to prevent infection. And we know that, when people are tired and their immune system is down, they get sick, they get colds, they get flus, and I think the same thing applies to COVID-19. And I'm unaware of any prevention drug at this point. If the other speakers do, I would love to hear about it.
So, Damon, I'll just say that, again, our president has certainly been touting hydroxychloroquine and azithromycin. The science studies, the kinds of studies that the American Heart Association, American Stroke Association would look at, they are very, very, very weak weak at best studies. The best they are studies that would indicate the need for more study. They're promising at best, but not very well conducted. And right now, there are a number of clinical trials going on globally, and clinical trials is the fancy word for well-designed and well-monitored studies that would give us the kind of information that would help us have a much higher degree of confidence about whether it is something that works or maybe it's something that really doesn't work. We don't know yet. And that's kind of the best. And then there's another body of work going on in Europe around BCG. And I, unfortunately, maybe Peter or Denise know what exactly that stands for. But BCG is a vaccine, if you will, that's been used for tuberculosis. And it seems to have as a side effect a protective effect against some viruses, influenza-like viruses. And there is a proposed set of trials to look at using BCG to address COVID-19. Those things are down the road. So I would just go back to what Peter was saying. The only thing we have right now is what we can each do as individuals and keep COVID-19 from spreading even in a more accelerated way, while the science is able to get us to the place where there is some treatment available, and to the place where there might be a vaccine or vaccines available, all of which are 12 to 18 months away at the shortest and probably longer away.
Hey, Damon, just jumping in here real quickly. And because of this premature conversation about hydroxychloroquine being a treatment or preventative treatment for COVID, it is definitely, we're feeling the effects already in St. Louis, having a shortage of that drug for people who truly need it, who have autoimmune diseases like lupus, and other conditions where they have to take this medication on a daily basis. So our pharmacies are already having shortages of the medication for the people that truly need it at this present time.
I can share, I have a family member that has lupus, and she was lucky to get an extended prescription just yesterday for it here in St. Louis. Denise, since we're still talking, I want to get your insight on this. People are getting food via carryout. Are there risks associated with eating prepared food? Could it be contaminated?
So what I would recommend that you do, so if you're doing DoorDash and Grubhub and all these type of delivery services, they need to be leaving it on your steps. I mean, because you still need to be participating in your social distancing. When you get these packages, you need to clean off the packages, because again, we talked about how the virus can be on surfaces. So you need to clean off the packages, and you need to wash your hands before eating the food. So if people are preparing food who are sick, yes, that's a risk. But this is why we are teaching everyone, if you are sick in any way, you're coughing, you have a fever, you have diarrhea, you should not be at work. And so these are the messages that we need to be sharing with everybody. So whenever you eat out, even not during a COVID-19 pandemic, there's always a risk of having food contaminated if the person who's preparing your food is ill.
Wow. Yeah, this has been an unbelievable conversation. Of course, I'm participating in it and getting it firsthand, but we truly appreciate everything that you all are sharing. We want to thank you all. Sorry, I got one more message that we may want to ask, a question we may want to ask. Okay, what we'll do, since we're getting close to time, we will answer any other questions that have been posed. There's one on asthma, for example, and not being addressed right now. But we're short on time, like I said. So We'll answer those questions via email as well as others. Again, this will not be our last community conversation, but our first. And before I close, I just like to invite each of our panelists to share a final thought. Denise, we'll start
so
with you.
again, thank you.
Yeah.
Thank you again for the invitation to join you. What I would like to say is that we have public health officials for a reason. They follow trends, they follow the data, and they help keep our community safe. And so at this present time, I encourage each of us to follow the recommendations. Stay home. Your life is more important than you running across town to hang out with your friends. It's important right now that we each do our part to combat COVID-19.
Thank you, thank you. And I hope the person who has asthma saw the comment from Dr. Sanchez in the chat box. Just make sure you consult and contact your health plan or doctor immediately. Denise, thank you for your thoughts. Peter, what final thoughts do you have?
Yeah, I certainly echo those as far as self-protection, which is community protection. I think the other thing that this pandemic has really outlined to a lot of us is how we, I think, maybe underappreciate each other and people in our community who take care of us on a daily basis. And I hope when this is over, or even as we're in the midst of this, we really kind of appreciate the people that really keep things moving, keep us fed, keep people going from point A to point B, and our colleagues that are all trying to do the right thing. And one thing that's been reassuring this whole past month or so is really the increased collegiality and kind of conversation and mainly communication between individuals that previously had very limited contact. And I hopefully we can take that away from this and continue that moving forward, because I think there's huge gains from that.
Thank you, Dr. Panagos. Dr. Sanchez.
And this is Eduardo. You know, I'm just going to keep it light and short. In a nod to Black Eyed Peas, act contagious, not outrageous, and just do what you can to keep yourself from infecting others and getting infected yourself. Last thing, one of the things that we've done at AHA to kind of lighten things up, because the other thing is it can't all be doom and gloom, is that we've done this haiku challenge. Damon, you're probably aware, and I'm gonna close with a haiku. Coronavirus is a serious matter. Act like contagious. Thank you for having me. Thank you for doing this. And thank you, Denise and Peter, for participating. And all y'all on this, if you're still on, thank you for what you're doing every day to take care of others and to take care of yourself.
This concludes our COVID-19 community conversation. Until next time, stay safe, stay healthy, stay connected, and if possible, stay home. Thank you all for joining us, and thank you for our panelists.
Thank you, everyone.
Thank you.
Bye now.
Take care.